there's just so much.
You're listening to a Mamma Mia podcast.
There are some people who develop problems with their drug use because it's serving some underlying function for them. It's a way to cope. And so for people with sort of depression, particularly sort of trauma or PTSD, we see that a lot, where the problems people are trying to cope with are often around sleep, for instance, or nightmares, or feeling really on edge around other people.
Hi there, I'm Claire Murphy. Welcome to Well, your full body health check.
And I'm Dr. Mariam.
Today we're talking about drug addiction. It is not an easy thing to face, so we're going to get educated today, which is really important. Find out what makes us become dependent on drugs, what the long-term impacts might be on our health, and what drugs are actually the most addictive. We'll also be getting into the doctor's office today to solve a problem for Simone, who will definitely not be starring in a Happy Feet remake anytime soon.
Or some OnlyFans.
She's not opening an OnlyFans for her feet fetish, no.
Oh, so sad.
But next, Mariam, we're going to go on a field trip to London.
Oh.
Are you prepared to come with me?
Sure am.
We are going to find out the deadliest item in the Vagina Museum.
There's a Vagina Museum.
There is a Vagina Museum. It's time to go to med school.
Welcome to med school.
In London, there exists the world first bricks and mortar Vagina Museum. It's in Camden Market if you do want to go and have a look on your next Euro adventure, or if you live there. Pop in and check it out. Have a look at the history of the female reproductive system. What do you think, Mariam, would be the most deadliest object on display in the Vagina Museum?
I'm thinking instruments from the old school unsafe abortions.
Ah.
All those old school vibrators.
Deadly vibrators?
Yeah, the deadly vibrators.
I mean,
orgasm and die.
I mean, there are worse ways to go, I guess. The old school abortion tools would have been a good one, and there's possibly that in there too. But it is not the deadliest item at the Vagina Museum. It's a tampon.
Oh, tell me more.
So they have on display a 1970s Procter & Gamble Rely tampon. Now, back in the day, this was promoted as being able to hold up to 20 times its weight in fluids.
Jeez.
But its unique design, it dried out that area, which meant it would also dry out the vaginal wall.
Yep.
And then it had this kind of flared tip that made it easier for insertion. So when you removed that tampon, it would potentially create tears in the vaginal wall. And what that then does is allows the natural flora that exists in your vagina, which is there every day to do its job, into the blood system.
Yeah.
And that includes bacteria like S. aureus.
Yes.
I think that's how you pronounce
Staph aureus,
it. Staph aureus. The gel inside the Rely tampon too, it had this crazy
There was a gel
inside. And you know the agar in like a petri dish where they grow bacteria? Yeah. It essentially did that but inside the tampon. So it made it like this perfect environment to grow it. This was not an issue if the tampon was only used for a really short period of time. But if you left it in for longer, say for example like you could a tampon that held 20 times its weight in volume.
Just going to leave it there for the duration of my menstrual cycle.
Exactly. And even on the packaging at the time, they only asked you to change it once every 24 hours.
Yeah.
So that was creating this wonderful, glorious environment for all of these bacteria to grow initially, and then when the tampon is removed, to get into the bloodstream. And what that would lead to is toxic shock syndrome.
Yeah.
TSS, as we know it, killed 73 women between 1970 and 1980. So between 1970 and 82, there were 1,588 confirmed cases in the US. 92% of those were contracted during their menstrual cycle. And that's how they ended up linking it back to this particular tampon.
Yeah.
In 2025, TSS due to tampon use is considered very rare. So you can get toxic shock syndrome other ways, but linked to tampon use, it is incredibly rare. Some data is suggesting now it's maybe as low as, say, 1 in a million, which as we know is pretty rare. But still, please don't leave tampons in for too long, even if they are much safer these days.
It is very rare. But I always tell people just put reminders on your phone, put an alarm clock, because it can be quite easy to forget how long you've had it in there.
Yeah, if it's not on day one where it's a crimson tide, like you might think, oh God, it's been a while.
Exactly, right? Especially if you're not leaking or anything like that. Alternate with pads or cups if that feels right for you. But yeah, if something feels off, you get a fever, rash or dizziness, always check in with your GP. I'll be honest, I've seen so many patients who've come into clinic with a weird odour or discharge.
Oh, now you've mentioned this off
Yeah.
air before. There is a very distinct smell of a tampon that's been forgotten about, right?
Yeah, that's right.
Yeah.
I identified it as the retained tampon smell. But yeah, so they'll be like, what's happening? I don't know what's happening down there. I think I've got an infection. And I'll do a speculum examination. Behold, there's a retained tampon. It's really common. Like there've been times when I'm like, have I put a fresh tampon on top of my old one? Or,
Yeah, because that's the thing too.
Yeah.
Sometimes, you're in the rush, you've got mental load happening, you forget that maybe you've already got one in there and pop a quick one in just on the run out the door, especially if you're using like the smaller ones.
But yeah, so I just put reminders on your phone. I know, just another thing to do. Vaginas are fun.
They do require some maintenance.
Yeah.
And one of those things is to not leave tampons in for very long periods of time. All right, it is checkup time. We're talking drug addiction today, and we're talking about things like methamphetamines, cocaine, cannabis, nicotine as well. So whatever your vice is, we are checking in to see how we can help tackle it and get you healthy.
It's time for the checkup.
This year, Mariam, according to the Australian Criminal Intelligence Commission's 2025 Wastewater Analysis Report, which I am weirdly obsessed with, it tells us a lot about us as humanity, what we flush down the toilet. Basically, they check the sewage to see what you have excreted, and that includes drugs. There has been a sharp rise in drug use in Australia. It showed Aussies consumed an estimated 22.2 tonnes of methamphetamine, cocaine, heroin and MDMA or ecstasy between August 2023 and August 24. That's huge amounts.
That's a lot, yeah.
And that is up 34% from the year before. So there has been quite a spike. The drug trade, as we have found, has more than bounced back post-COVID. As we knew when we were in lockdown, those supply routes were severely compromised and shut down almost. And they still attempted to get it out into the community, but it was not as easy. But cannabis is still the most consumed illicit drug in the country. Look, I'm sharing this for honesty and some transparency. This is absolutely not encouragement. If you are concerned about your own use issues, please reach out because support is available. I have used recreational drugs in the past. I'm not going to go into detail about what, when, or how often because that is irresponsible. But I have dabbled, and I count myself very, very lucky that I have not taken something that has hooked me and that I've managed to avoid addiction. I actually feel like my addictive behaviours is more centred around food and sugar and things like that. But I have friends who have not been so lucky, and I have people around me now who are struggling with drug addictions. And Mariam, drug addiction is a really significant issue for Aussies. We've spoken about alcohol already last week, but while the rate of smokers, so nicotine addiction, has declined over the past decade, in 2022, for example, still more than 10% of Australians over the age of 15 smoke cigarettes daily. Vaping also too has surged in the space where smokers have vacated. So in 2022-23, 21% of Australians aged 18 to 24 reported vaping at least once in the previous 12 months. Almost 1 in 10 in that group vape daily. And the fact teen girls are reporting higher vaping rates than boys is really concerning.
I'm seeing them everywhere in the shopping centre. Girls in school uniforms just with a vape in hand.
Do you know what scared me is we'd get notes home from school. This is primary school. Please don't vape on the bus.
Oh, my goodness.
These are primary school aged kids. And that's the problem, is because they come in all these fun flavours and it seems like a really innocent thing to do, and maybe you think you're cool. And we've all been there. I've smoked cigarettes when I was socially drinking because I felt like it was a cool thing to do.
Yeah.
It's dumb, but when you're younger, sometimes you don't make those considered choices. And so the fact that vaping has hit younger and younger and younger kids, that is truly terrifying. The Department of Health figures are pretty stark too. They found that 1 in 6 Australians used an illicit drug last year, and 1 in 4 are drinking at risky levels, which we talked about last week. And that suggests that there are likely more than 2 million people battling a substance use disorder in Australia right now. And that doesn't even include things like gambling or shopping addictions. Are you seeing many people in your practice coming in for drug issues?
Look, sometimes it's very direct, and I get people come in and say, hey, I think I've got a problem with drinking or using, and they're ready for help. But more often it's indirect patients coming through. So they might be booking in for poor sleep, anxiety, stomach issues, lots of relationship issues. And then as we talk, it becomes quite clear that substance use is part of the bigger picture. And then there's patients who will tell me, look, I don't want to be here. My partner or my mum made me book this appointment. And that's really common too. Sometimes that external push can open the door. But lasting change usually comes when the person comes in themselves and sees the value in the support rather than being forced to come because someone's made them come in, unfortunately.
There's that whole thing like you can't help someone who doesn't want to help themselves, right?
That's right, yeah. The tricky part is that people often expect judgment. They'll imagine I'll just lecture them to stop, but that's just not how we practice, and it's not how modern healthcare works. It's to meet someone where they are, ask what they want out of the consult. What do you want to achieve? What do you want to do with this? And then work on the safest, most realistic next steps, whether it's harm reduction, mental health support, or referral into specialised services. Yeah.
How do you actually get someone into rehab for drugs, though? We looked at that with our expert last week with alcohol. Like, is it a pretty similar process?
Yeah, so the first step is always checking in with your GP. We're the ones who can do that assessment, check in on your physical and mental health, because we know that addiction can affect all aspects of your health, and talk about what kind of support you're actually looking for as well, because that's going to be a big part of it. Not everyone needs that live-in residential rehab. People do really well with outpatient programs, counselling, peer support groups, or even medication-assisted treatment programs, depending on the drug involved. If residential rehab is the right fit, your GP can do the referral for you. In Australia, this usually means a letter with your medical history, details about what substances you're using and why rehab is being requested. And from there, it depends on whether you're looking at the public system or the private system. And that can come, unfortunately, with significant costs. For some substances like opioids, there's also specific programs that we can connect people with, like the opioid treatment programs that use medications, which might be a step before or instead of rehab. So there isn't a one-size-fits-all. It all depends on the person, their preferences, and their drug of addiction as well. Process is very much GP-led, so they'll assess, refer, and then support you through the wait and transition, which is also important. It's not like, here's your referral letter, see you later.
Yeah.
It's really important to have that ongoing support and review by your GP to ensure that we're looking after you before we connect you with those groups.
There's one thing I found out in making this podcast with you is that humans are so freaking different from one to the next that we do try to bring in these things that can help as many people as possible, but everything really is so specific to you, right?
Yeah.
So what rehab works for one person might not work for the next, right?
Exactly. It's the same thing with when I refer people to psychologists, like there'll be one that I'm like, oh, wow, I've had 2 great patients do really well with this psychologist. I'll send another patient there and they'll be like, who the F did you send me to?
Yeah.
It's got to fit your lifestyle. It's got to work for you. And you've got to be in the right headspace for it.
Yeah. All right, we're going to get into this a little bit more with Dr. Shalini. She's going to give us the lowdown on drug addiction, how to see if we're dabbling or reaching dependency territory, and what is the most dangerous and the most addictive drug in Australia.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
Quick note before we go, this is general information only and not medical advice. Treatment options, including prescription medicines, aren't suitable for everyone and need an individual medical assessment. So please don't start, stop, or change any medicine based on this episode. Please speak with your GP or pharmacist first. Dr. Shalini Arunogiri is the Clinical Director at the Statewide Centre for Addiction and Mental Health. She's going to take us through a few things today, and we kicked off our conversation with her by asking, when we do take drugs, what are we even addicted to? We'll start off with, I think, something that maybe we don't fully have a handle on, and that is, what is it about drugs that hooks us in the first place?
Yeah, it's a really interesting question, Claire. What we understand is what we consider drugs. So really, we're operationalizing that by substances that give us pleasure, primarily, that do something for us, whether that be mentally, psychologically. So when we think about what we consider drugs, or even what we consider behaviors that we want to keep going back to and doing over and over again, it's because they're usually performing some sort of function or role for us, that people might get pleasure in the moment. It might serve some sort of positive effect for people. And that sometimes can become then down the track into a problem.
And when we say it becomes a problem, does it change us chemically within our brain? Is that what we're striving for? What is it about that substance that makes us yearn to go back to it over and over?
So what we know about most substances that we consider drugs is the first few times you use it, you're actually getting a reward chemical release in your brain and through your body. Sometimes that's chemicals like dopamine or serotonin. So we're actually getting a bit of a hit of positive effects when you first start using the chemical. But over time, what we know is with anything that we use repeatedly that has some downstream effects, when people start finding that they have a problem with the thing, what we usually find downstream is that those initial positive effects sort of wear off, that people need to use more to get the same effect from that. Also, those chemical pathways in the body and the brain start changing. So your body and brain get used to being exposed to that chemical. And so over time, what you end up seeing is not only that you need to use the same amount to get the same effect, but you stop actually getting the positive effects. You start getting a lot of the negative effects. So the withdrawal symptoms that happen if you stop using the chemical.
And I don't know if we even rank them like this, but what would you say is the most addictive drug?
Yeah, this is a really interesting question, actually. There are rankings out there, and a lot of the ways that the rankings are sometimes operationalized is more around whether the drug is illicit or licit. So whether it's actually accessible in the country and what sort of frameworks that the country has put around it.
Okay, so we're including things like street drugs as well as prescription drugs, and whether you can even access that drug in Australia.
And when we think about, if we broaden that up, that includes alcohol, it includes tobacco, it includes things that are illegal, it includes things also, if you start to really broaden it up, it includes behaviors like gambling or other behaviors that can then also become problematic. And so sometimes when we think about something, about whether it's addictive or not, it's less actually about whether the process is addictive. It's actually also about what the society kind of thinks about the substance. So, if something is illegal, illicit, people often have to engage in different behaviors to get the substance. You can't just walk down to a bottle shop and buy it. And so the problems that can arise from using it can also be about how it actually is accessible or inaccessible to you. But when we think about what's really addictive, I guess one of the things that we think about is how much of a reward or a positive effect you get in the brain or the body when you first use it. And some of the stimulant drugs are potentially more addictive from that perspective because they cause more of a rush of sort of dopamine or other things to occur in the body and the brain. And over time, that can be problematic. But broadly speaking, if we think about what sort of drugs cause the most harms actually for us in society, across most countries, across most societies, that's alcohol. And that's also partly because it's so accessible too.
When you say stimulants, what do you mean?
So that includes cocaine, it includes amphetamine and methamphetamine, it includes MDMA or ecstasy, and then a range of other substances that are sort of newer in that category as well.
So you've kind of outlined then what our most dangerous drug, would that also be alcohol, if you were to put it in that framework?
Depends how we define danger, but I think from a population health perspective, in terms of everyone who uses the substance, the harms we get, alcohol would be probably at the top of that list. But then when we think of an individual level, like if someone is using a substance, it's also kind of thinking about what those harms are for that individual person. For some drugs, people are also choosing to use it. For alcohol, for instance, you're drinking that, you're using it orally. For some substance, you might be injecting that. And so there are particular harms that come with injecting drug use that can also be really problematic. So those harms are also part of the picture. It's less about the drug also there. It's about the way that someone's using it.
Can I get your opinion on cannabis? Because it is often spoken about like one of the least harmful drugs, and a lot of people will spruik it like it's a plant, so it's natural. Or the other side of that argument is it's a gateway drug and it'll start you down a slippery slope into taking other things. And then there are people who say Smoke it once, you could end up experiencing psychosis that is actually quite dangerous. Where do we stand on the cannabis debate? I mean, it is legalized in some places in the world now, so where are we at with that?
Yeah, it's a really fascinating discussion. It highlights also, I think, when people think about these things to find reputable sources of information as well, because there's such a wide variety of different things that people think and talk about in relation to cannabis and other drugs too. But with cannabis, I think what we know is the plant version of it. So if you're growing and having that version of it, that's quite different also to what people might be getting from a medication supply versus also what people might be getting from, say, dispensaries in some countries. And what we know is that the potency is quite important in terms of the types of chemicals that are in the cannabis plant. And the higher potency can be associated with more harms than perhaps some of the lower potency versions of it. But it's not something that is without any harms. I guess in terms of the spectrum of different problems that people can have, it's not a chemical that has no harms at all or no risks at all. And, many societies, we have very high prevalence of cannabis use. Australia is probably towards the top of that list, actually. And we know that overall, across the population, the harms associated with cannabis are quite low. So we don't expect a large proportion of people to become dependent on it or addicted to it. And we also don't expect that the vast majority of people experience a lot of harms. But what we do know is that there are a minority of people who might develop psychosis. It's rarely from a one-off use. It's usually from repeated use. But psychosis and other mental health problems, anxiety disorders or depression, are also things that we worry about when there's regular use. And we kind of have to think about that in the context of the person who's using it. What are their risk factors for kind of developing those problems? And when you add cannabis to the mix for some people, that can result in some major problems. And we particularly worry about it for younger people, for teenagers, because there's quite a lot of evidence about smoking earlier and starting that onset earlier, causing a lot more problems down the track.
You've mentioned mental health issues there, and I'd love to get your take on what is true, and I'm presuming both of these can be true at the same time, that taking certain drugs can cause mental health issues, or is it because of the mental health issues that people take drugs?
Yeah, it's $1 million question. And I think the reality is it goes both ways. There are some people who develop problems with their drug use because it's serving some underlying function for them. It's a way to cope. And so for people with depression, particularly trauma or PTSD, we see that a lot, where the problems people are trying to cope with are often around sleep, for instance, or nightmares, or feeling really on edge around other people. And so substances can be a really effective way to kind of cope with that. And so that direction is really about having the mental health problem first and the drugs helping with that. Within treatment services particularly, we also see the opposite really often, where people have developed a problem from the drug and the drug has precipitated mental health problems. So for instance, with alcohol and other drugs, they can directly cause depression, whether or not you had that before, whether or not that you have any risk factors for it. The drug can directly cause it. Psychosis is another big category of mental health problems that can directly come from the drug itself. So both things can happen. I think for people who are struggling with both problems, though, I think the important thing to know is really to find someone who can help you manage both of those things together, rather than splitting them off or trying to figure out which one's driving which, as you kind of have to really look at the two together.
Do people with substance abuse issues ever fully recover? This is something I've been thinking about because a friend of mine who struggled with alcohol addiction, she refers to herself as still being in recovery, even though she's been years and years sober. So there's this idea that you're never really truly recovered from substance dependence. Would you say that's true?
Yeah, I guess this question is partly about recovery, but I guess one thing I wanted to touch on there is also the level of stigma that sits around substance use, drug use, and alcohol use. And I guess the power of language as well and how we kind of think about this. Generally in the field, we don't use words like drug addict or alcoholic, partly because it also identifies the person as being their problem, that they're nothing more than really that problem. And when we take a step back and kind of think about the vast majority of people who have substance use problems, it's really a little window or episode in people's life often. And so in that broader recovery context, we do actually see people sustain recovery and obtain recovery. In fact, if you think addiction really is a health problem, similar to any other health problems, we wouldn't think necessarily of someone with diabetes or with asthma, with these problems where you can have episodes during that period of not being in recovery from the diabetes or the asthma. It's something that some people live with for long periods of time. And then you also have some people who are able to kind of achieve and sustain that without ever really having many lapses again. And it kind of comes down to whether people can access support. whether they can access treatment as well. And we know there's some major barriers, stigma being one of the biggest ones, actually, of people being able to kind of get that support and help early on as well, and not sort of waiting and being afraid of kind of reaching out and worried that they'll be judged or shamed for reaching out. And so the earlier people can get help, the better.
If you were to say, what does a drug addict look like to you? There is an immediate vision that would pop into most people's heads, I would imagine, of someone who's potentially homeless and living on the streets, or a junkie. Like, that's the kind of pop culture image of what someone who is addicted to drugs looks like. Do you think we'll ever be able to shift away from that stigma? It seems to be pretty well entrenched. I mean, in Australian society, I presume globally.
Yeah, look, I think it is well entrenched, but I also think that, if we look at the mental health space, it used to be that we never used to talk about depression, suicide. In fact, if we go back a bit further, we never used to talk about cancer. So there's a real kind of shift in these health problems over time. And I think the media has a big role to play, of course, here in terms of, the portrayals of people who use substances in the media. But I think equally, lots of celebrities, lots of people in the media have played a really big role in kind of sharing their own experiences, sharing their own journeys of being in recovery. And that plays a huge role in trying to shift some of that perspective as well, I think, for people. The more we can share these stories, the more we can be sort of open and shifting that sort of stigma and the bias. The vast majority of people I see in my practice don't fit that stigma or that stereotype. They're working professionals, they're, people with families, with kids. They're also part and parcel of having that stigma applied to them, that people would never think that they have a problem with drugs, and it makes it even harder to get treatment if that's the case.
When you're looking at getting treatment, how much of treatment for drug addiction is, say, therapy-based as opposed to like pharmacologically based? Because we know, for example, someone who might have a problem with heroin can take methadone. Like, how much of that is being deployed now to help people who have issues with drugs?
There are some really promising kind of medication treatments, but not for every drug. So opioids, for instance, it's great that there are effective medication treatments for opioid use, be that, actually heroin, but also pharmaceutical opioids. So if people develop dependence on their prescription medications, their prescription opioid medications, these sort of treatments, methadone, buprenorphine, are really effective for that as well. So we know for opioids, that's an option. For alcohol, we have a number of other medication treatments, but the vast majority of treatment is what we call psychosocial, which involves kind of psychological therapy, counseling-based approaches, behavioral treatments. It involves also support, and that support can play a variety of different roles, whether it's mutual support from other people who are in recovery, or also from family and friends. So actually assisting family and friends to be able to support people best as well.
Is withdrawal across the board, or does it look different depending on what drug is your issue?
Withdrawal is largely dependent exactly what people experience in terms of the symptoms, how long it goes for as well. That is largely dependent on what the person's using, and also, importantly, how often they're using it and how long they can go without using it. Not everyone who uses substances semi-regularly is going to experience a withdrawal when they stop using. There's a range of kind of factors. And I think for women who use substances, the interesting factor there is also we don't really fully understand which parts of, say, the menstrual cycle actually affect how severe your withdrawal syndrome is. It's really only in the last 5-10 years that we've started unpacking that and looking at what's happening in women's bodies during different parts of the cycle. And so, for instance, we know that at some parts of the cycle, it's easier to quit smoking than at other parts of the cycle. And so it's fascinating, the kind of different kind of inter effects that each individual person actually will have that impacts on their withdrawal syndrome. And for women, there's a whole range of factors that I think health professionals just may not be fully across yet when we're trying to unpack this.
When we're talking about recovery, can you ever really put a time frame on it? If you were, say, a prescription opioids is the issue that you have and you've been sort of moderately using for 6 months, could you then say that there is a time frame that we could potentially give you with those factors in mind?
Yeah, I think that withdrawal phase, particularly, we can give fairly accurate timeframes. So, for instance, with some substances, I mentioned stimulants before, if you're coming off amphetamines, methamphetamine, we know that that's going to take a few months before you're kind of fully through that phase of your body and your brain not being used to having that around. So we know that initial phase can be a few months. But when we think about that longer term recovery phase, it really comes down to what else is happening for someone in their life, because it's really kind of, understanding the relationship between the substance use and what you're using to help it cope with, and then also who else is in your life, the amount of support people have. And We really know that being able to engage early in support and also being able to draw on support. So if you've got a spouse, a family that's supportive and you're able to be open with that, you've got family members who are well supported themselves, you've got a community around you, all of those things mean the recovery, like getting into recovery and sustaining recovery is much easier and the prognosis is much better.
Once you have started that journey, though, how common is it to relapse when it comes to having issues with drugs?
Yeah, again, it depends how long it's been going on for, I think, for the person. When we work with people, we tend to be pretty open that that's an expectation rather than, failure, that we're expecting that relapse is going to be part of that process. And relapse is also an opportunity to kind of learn and tweak what we're doing in terms of an individualized kind of treatment approach. Overall, we might have a counseling-based approach, but we might say, 2 or 3 sessions in, we're going to need to really understand when the rubber hits the road, what's going to get in the way of this for you in your life. And that's when, people need to be able to have a really open discussion and open understanding of that for themselves, what's going to get in the way. And the lapses and the relapses allow you to be able to test that, to understand that, what's problematic, and people can then unpack that hopefully with the support of counsellor and the treatment. So really relapses is the expectation, is the norm really, and that's what we work with people with, particularly in that early phase. And then over time, as people learn more about themselves and what it is that is driving them to use this particular substance, they're able to kind of sustain that for longer and engage in kind of supportive approaches, be that, maybe taking up particular types of exercise or hobbies or other things that are actually replacing what that drug was doing for them as well in their life. And then that gets easier and easier as time gets on.
You mentioned this earlier, that there are some barriers for people accessing treatment. What are those barriers, and what suggestions would you give to people who might be hearing this right now who are struggling with substance abuse? Where do they go? Where do they start?
Yeah, I think one of the biggest barriers, as I mentioned before, is stigma. It's that fear that both in terms of how other people in society might judge you, but also internally, I think there can be a lot of what we call self-stigma around sort of shame and blame and guilt, and people feeling like they don't deserve care or they don't deserve treatment. So I think together those two factors are probably the biggest reason why people don't reach out for help. Then the second reason is also people often don't know where to go for help. We know that health professionals often don't have the level of understanding and knowledge to treat addiction as we wish they would. And that often comes down to the way the training is organized and undergraduate training is organized. People often don't get exposure to being able to treat these problems. So for an individual who's kind of trying to navigate their way to, what's the next step, I think even if people are starting to think about maybe I have a problem with something, there are lots of online supports that people can engage in initially to try and just see where they're placed and what they want to do next, to try and consolidate their thinking around that. There's a website called counsellingonline.org.au, and on Counselling Online there's a self-check tool, so people can do a quiz that might be around the substance that they're using and understand where that fits in terms of whether that's problematic or not. And then there's a whole range of resources and pathways that website will direct people to, including what's available in their region, but also what's available online. And what we know is also there are online supports that we offer. Many more women access these websites and the online supports than the face-to-face treatment. And the majority of face-to-face treatment, regardless of the primary drug that people are using, we get about 60 to 75% of treatment entrants being men rather than women. And then when you go onto the online and the telephone-based programs, we get much higher proportions of women accessing these services because they don't come with the same sort of face-to-face level of stigma and barriers that women access otherwise.
So I was a little bit shook to find out that rehab doesn't have to cost a packet. I was always under the impression that you had to fork out thousands for it.
Yeah, very common misconception. People often think rehab automatically means like these expensive private facilities with celebrities.
I think that's the thing, because most of our reference is only like when celebs go off to the Betty Ford clinic. Like that's all we know, right?
It's somewhere up in the mountains.
Yeah, it's in Malibu.
Yeah, no, that's definitely not the only option here in Oz. We actually have a really good mix of public and community-based rehab programs that are either free or low cost and usually funded by state health services or not-for-profit organisations, and you can access them through your GP, a hospital, or even directly by referral. But private facilities do exist. They can be pricey, but it's not the only pathway to recovery. What matters most, as we've mentioned, is finding the right fit for you, whether that's inpatient, outpatient, or a combination of counselling, group therapy, and medical support with your GP.
Amazing. Thank you so much, Dr. Shalini. That's really important information. Next, we are heading into the doctor's rooms to ask a question for Simone, who has very unhappy feet.
Oh, see mine.
It's time to answer a question from you. It is very easy to get your questions into the queue here. Just hit us up on the Insta DMs. You can email well@mamamia.com.au or join us in the waiting room. It is an anonymous online form and you can find a link to that in our show notes. Okay, doctor, if you would please.
The doctor will see you now just through here to consult room 1.
Thanks for waiting. How can I help you?
Simone's feet are causing her some issues. She wrote this to us.
I have inherited bunions. I had my first surgery at 16, then another 10 years ago, plus the correction of a hammer toe. So one foot's okay, but the other side is not so good. And the big toe is turning in and it's actually causing painful friction and a callus or corn. Can this even be surgically corrected a third time?
Bunions, huh?
You inherited bunions too, didn't you?
I inherited bunions. Oh, gotta love them. Answer is yes, but it's not as straightforward. No pun intended.
Oh, that's mean.
As the first or even second go. So revision surgery is definitely possible, especially if she's got some issues and there's the painfulness with the friction. But we know that previous surgeries can leave scar tissue and change the anatomy of the joint and alter the way the foot moves. So all of that makes the next operation a little trickier.
Right, so we've got to take all that into account now.
So you'd want to see a specialist ortho for foot and ankle, and they'd probably do some advanced imaging and talk to you about what the next best option would be. You know, so it's bunions themselves aren't actually dangerous. It's what they can cause. They can be uncomfortable.
So what is a bunion?
Yeah, so a bunion is the bump that forms on the side of the big toe. And what happens is it pushes it inwards and then the other toes kind of compensate.
So it's like the bump is like sort of where the joint is that attaches it to the foot part,
It's the
right?
base of
one,
the big toe. And so over time, the muscle and tendons in those toes can become imbalanced.
So it's pulling over to one side,
And that's when people can get the hammer toe, And it's called a hammer toe because it looks literally like a hammer.
Oh, I did not realise that. I thought it was just like a stunted toe.
And so, you know, you can have issues fitting into your shoes. It can affect the way you walk. But yeah, if it's causing pain and those issues, then that's a strong reason to see an orthopedic surgeon to consider an operation would be a viable option. That would be my advice. There are always non-surgical things to try in the interim, whether that's wider shoes, padding, orthotics.
My mum uses corn pads. Is that a thing?
Yeah, it is. It just kind of helps prevent them
Stop
getting
the
worse.
friction. Yeah.
They won't fix the bunion itself, but might buy you some comfort while you decide what to do next. So I would start with seeing your GP and get that referral to orthopedic surgeon who specialises in the foot and the ankle. Yeah.
Okay, so it can be done, but there's a lot more to take into account.
Yeah, that's right. Yeah.
Well, Simone, hopefully that helped you out a bit. Go have a chat to your doctor, see all the things you now need to take into consideration. Maybe third time's a charm.
Hope so.
You never know. Thanks for hanging out again today, friends. Get your questions into Mariam. But remember, the information that you've heard here today is general, not specifically for your situation. Take what you've learned to your healthcare team and make sure you get the info that is right just for you. Next week, we're catching up with David Hughes, as you probably better know as Hughesy, iconic Australian stand-up comedian, TV and radio presenter. Those of you who know Hughesy know he's famous for that unmistakable voice and his fearless honesty, often frustration-fueled take on modern life too. But what you may not know is that Hughesy's been completely sober since his early 20s. He walked away from a debilitating struggle with alcohol and drugs before his career even took off. Instead of letting addiction write his story, he built a comedy empire. I'm going to be sitting down with him and talking about the rock bottom moments that saved his life and what it's like to navigate the high pressure and often, to be honest, quite boozy world of Australian entertainment without a drink in hand. You don't want to miss it. So we'll catch you for your appointment this time next week.
Bye-bye.
Well is produced by me, Claire Murphy, and our senior producer, Sally Best, with audio production by Scott Stronach and video production by Julian Rosario and social production by Ellie Moore. And if this topic has raised some concerns for you, please contact your GP or call the National Alcohol and Other Drug Hotline on 1800 250 015. Mamma Mia acknowledges the traditional owners of the land we've recorded this podcast on, the Gadigal people of the Eora Nation and the Wonnarua people. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander cultures.